Hi guys, welcome to episode 4 of the INICET Medicine PYQ series, where we are discussing the previous year questions which have come in the INICET exams because they are often repeatable questions and it might help you crack these questions. So let's get started. So the first question, mark the correct statement regarding inflammatory bowel disease, and the options are: skip lesions are present in Crohn's disease, mucosal layers are involved in Crohn's while transmural involvement is seen in ulcerative colitis, inflammatory bowel disease has a strong genetic predisposition, and Crohn's is curable through surgical resection of the affected segment. So let us go through each statements one by one and rule out which is the correct statement. So the first statement, skip lesions are present in Crohn's disease. So this looks like the correct statement. Let us see the other options as well. Option B, mucosal layers are involved in Crohn's while transmural involvement is seen in ulcerative colitis. So this is actually opposite. It is transmural involvement which is seen in Crohn's and mucosal layers which is seen in ulcerative colitis. So this is a false statement. Option C, inflammatory bowel disease has a strong genetic predisposition. Genetic predisposition is definitely known for IBD, but it is not a strong predisposition. Hence this statement is also false. And the last option, Crohn's is curable through surgical resection of the affected segment. Now since Crohn's disease have skip lesions involving multiple different areas of the GI system, so surgery is not curable for Crohn's disease. So this is also a false statement. So if you see, the correct statement and the correct answer is here is option A, that is skip lesions are present in Crohn's disease. I have made a complete video of Crohn's versus ulcerative colitis in the PYQ series which I was making for the Neet PG. You can quickly revise the topic from there if you want. I'll put the link in the description below. You will find in the I button. Moving forward, a 40-year-old man presents with 15 days of fever and altered sensation for 1 day. Rapid diagnostic test was done and Plasmodium falciparum was diagnosed. Which of the following is not a complication? The options are blood glucose less than 40, arterial pH more than 7.2, serum creatinine 5.2, and unarousable coma. So the diagnosis have already been given, that is Plasmodium falciparum, and they are asking which is not a complication. So let us first quickly go through the complications of Plasmodium falciparum. And Plasmodium falciparum is known to cause severe malaria. And the complications are unarousable coma, acidosis less than 7.2, renal failure, creatinine more than 3, urine output less than 400, and hypoglycemia less than 40 mg per dl, jaundice, convulsions, and many more. So if you see the option, blood glucose less than 40 is correct, serum creatinine 5.2 is correct, unarousable coma is also correct. But arterial pH more than 7.2 is alkalosis and not acidosis. So this is a false option. It is acidosis which is seen. So the answer here is option B, that is arterial pH more than 7.2, which is not a complication of Plasmodium falciparum. Next question, a person presents to the hospital with fever and chills, and fever profile is ordered and is found to be negative for malaria and dengue. RK39 test is found to be positive. What is the treatment of choice? Options are amphotericin B, griseofulvin, dapsone, and hydroxychloroquine. So they have already given that malaria and dengue is negative and RK39 is found to be positive. So RK39 antigen test is positive in cases of Kala Azar. So it is suggestive of Kala Azar. And drug of choice in Kala Azar is amphotericin B. Although it is not a gold standard test to detect Kala Azar, gold standard test is AMST-GOT forms in tissue aspirates. And RK39 is a screening test which can be done easily. So the correct answer here is amphotericin B, which is a drug of choice for Kala Azar. Moving forward, next question, a patient presents with fever and knuckle rigidity. The resident was instructed to perform a lumbar puncture on this patient. What is the correct order of managing this patient? And the options are: place IV cannula and give fluids at 40 ml per hour, start injection ceftriaxone, send CSF sample for biochemistry and microanalysis, and perform a guarded lumbar puncture. They have asked you to arrange these options in the correct order. So such questions are expected in INICET. So from the clinical features of fever and knuckle rigidity, it is suggestive of meningitis, for which lumbar puncture is mandatory and antibiotic should be started as soon as possible. Now the question is, which should be done first? So always a lumbar puncture needs to be done first before starting an antibiotic. So option 4 should be the first step, that is perform guarded lumbar puncture. Then option 3, which is to collect the sample for biochemistry and microanalysis and send it to the lab, and then immediately start antibiotic even before starting fluids. So the correct order should be 4, 3, 2, 1. So option C is the right answer. Rest on the basis of the findings of the CSF sample, further decision to taper the antibiotics or stop the antibiotics and change the treatment is decided. That is after the reports of the CSF sample. Moving forward, the next question. A patient who is a known case of HIV with a CD4 count of 200 presents with 5 days of cough and high-grade fever without chills and rigor. There is no history of diarrhea, vomiting, knuckle rigidity. Chest X-ray is normal. What treatment will you give? The options are amoxicillin, clavulanic acid plus azithromycin, cotrimoxazole plus steroids, cotrimoxazole only, and anti-tubercular treatment. Now, if you see the clinical stem, they have said it is HIV with CD4 count 200, which is suggestive of immunocompromised state. Moreover, history of cough is pointing towards a respiratory involvement. And also there is no history of diarrhea, vomiting and knuckle rigidity, which helps out rule out other systems. Now, chest X-ray is normal. So with the background of these findings, the most common opportunistic infection in such a scenario is PCP, which is pneumocystis cerevisiae pneumonia, and drug of choice for PCP is cotrimoxazole only. Steroids are generally not preferred as it can worsen the state. Amoxicillin and azithromycin are antibiotics which can be given if bacterial infection is suspected. But since the chest X-ray is normal, not showing any lobar involvement and not having chills and rigor, so option A is not the answer. ATT are given if tuberculosis is suspected, which is generally associated with a high CD4 count and chest X-ray abnormality. But since that is not the clue here, so that is ruled out. So the best answer here is option C, that is cotrimoxazole only. Moving forward, a patient presents with perioral numbness, tingling and tetany. All of the following condition can lead to this except vitamin D toxicity, acute pancreatitis, chronic kidney disease and hypoparathyroidism. So the symptoms given in the question are suggestive of hypocalcemia, and option B, C and D are associated with hypocalcemia. But option A, that is vitamin D toxicity, they actually lead to hypercalcemia because it leads to more absorption. Therefore, option A is the answer, which is not seen in such situation. Next question. An increased anion gap is seen in respiratory acidosis, respiratory alkalosis, metabolic acidosis and metabolic alkalosis. So first, what is anion gap? So it is sodium minus bicarbonate plus chloride, which is the formula to calculate if they have given the values and to calculate the anion gap. And a high anion gap is mainly associated with metabolic acidosis. Therefore, option C is the answer here. You can watch my video on acid-base disorders where I have covered everything in a nutshell if you want to quickly revise the topic, where I have discussed about anion gap, a high anion gap versus normal anion gap, how to approach the questions of respiratory acidosis, alkalosis, metabolic acidosis and metabolic alkalosis. The link you will find in the description or in the I button. So the answer here is option C, that is metabolic acidosis, where increased anion gap is seen. Moving forward, next question. An elderly female patient with a history of severe vomiting was treated aggressively for severe dehydration at an outside hospital. 1 week later, she became mute, quadriplegic and rigid. What is the most likely reason? And the options are malignant hyperthermia, severe catatonia, rapid sodium correction and neuroleptic malignant syndrome. So if we see the clinical stem, severe vomiting is a common cause of electrolyte abnormalities, particularly hyponatremia, and rapid aggressive correction with sodium is suggestive of such clinical features, leading to central pontine myelinolysis, that is CPM. And in CPM, there is demyelination at the base of the pons, and such symptoms like mute, quadriplegic and rigid are seen. It can be prevented by gradual correction rather than a rapid correction, with a target of less than 10 milliequivalent per liter within 24 hours. So option C, that is rapid sodium correction, looks like the answer. Now option A, malignant hyperthermia, it is generally characterized by sustained muscle contraction and fever, which is not the case here. Option B, severe catatonia, it characterized by behavioral abnormalities, stupor and posturing, etc., which is also not the case here. And option D, neuroleptic malignant syndrome, it is associated with increased pulse rate and BP and muscular rigidity and agitation. So these are also not mentioned in the question. So the best correct answer here is rapid sodium correction, which can lead to such a scenario, that is CPM. Hence, always a gradual correction is recommended. Moving forward, a young patient presents to the clinic with erythematous lesions over the exposed areas of the skin like hands, arms, chest, etc. She also complains of arthralgia and breathlessness. And the picture is given on the right hand side. And which among the following antibodies will be useful in diagnosing this condition? And options are anti-histone antibodies, anti-dsDNA antibodies, anti-centromere antibodies and anti-nuclear antibodies. So if you see the image and the clinical presentation, it looks like SLE, that is systemic lupus erythematosus, and they have asked the antibody which is useful for diagnosis. So ANA, that is option D, anti-nuclear antibodies, is useful, but it is useful for screening as it is more sensitive than specific. And anti-histone is generally associated with drug-induced lupus. So the best answer here is option B, that is anti-DS DNA antibodies, which is the most specific in SLE, and hence it is also useful in diagnosing this condition. So the answer here is option B, that is anti-DS DNA antibodies. So SLE is a very important topic, and often you'll find repeat questions from SLE regarding the antibodies. So make sure to revise this topic before going to the exam. Next question. A patient with diabetes, hypertension, CKD has elevated serum creatine urea levels. Which of the following oral hypoglycemic agents is safe to use? Glimepiride, GLP-1 analogs, vildagliptin and linagliptin. So they have given the options of the OHA, and they have asked which of the following is safe to use in a patient of CKD having increased serum creatine urea levels. So option A and option B are not recommended in CKD patients because of the renal clearance and dose modification needed. Now options C and D are both DPP-4 inhibitors, of which linagliptin is safe to use in CKD. You can remember linagliptin, L for linagliptin, L for liver. Linagliptin is cleared by liver, so there is no need of dose reduction in CKD. Linagliptin requires dose modification in hepatic failure. So the best answer here is option D, linagliptin, which is safe to use in such a scenario. Next question. What is the most common site of abdominal tuberculosis? And options are rectum, colon, small intestine, ileocecal junction. So this is a very direct question and a fact-based question, and the answer here is option D, that is ileocecal junction, and it is very commonly asked question as well. So the correct answer is ileocecal junction, which is the most common site of abdominal TB. Next question. Which of the following electrolyte abnormality is seen in methanol intoxication? And options are metabolic alkalosis with high anion gap, metabolic acidosis with high anion gap, metabolic acidosis with normal anion gap, and metabolic alkalosis with normal anion gap. So in case of methanol intoxication, methanol is ultimately converted to formic acid, undergoing reactions from alcohol dehydrogenase and aldehyde dehydrogenase, and formic acid is accumulated. So because of buildup of acid, definitely acidosis is expected. So options with metabolic alkalosis are ruled out. Coming to option B and C. So if we see the causes of normal anion gap versus high anion gap in this table, we know methanol intoxication causes high anion gap metabolic acidosis rather than a normal anion gap acidosis. So the best answer here is option B, which is metabolic acidosis with high anion gap, which is seen in this condition. Next question. A patient was treated for peptic ulcer with an H. pylori regimen. Which of the following is used to assess the success of treatment? And the options are endoscopy, IgG antibody study, urea breath test, and urea test of biopsy. So they are asking which is the best for follow-up. So option A is endoscopy. It is generally not done because it is invasive and it's difficult to follow up. Option B, IgG antibody. So serology, they are convenient and inexpensive, but they are not much useful for monitoring as they are non-specific. Option C and option D, urea breath test and urea test of biopsy. So among this, biopsy will be invasive, although specific. So better tool for follow-up would be urea breath test, which is the answer here. Although the best way to assess the success of treatment is endoscopy and urea test of biopsy, but because it is invasive, it is not done routinely. The last question. Patient has a fever, cough and cold, and the chest x-ray is given below. What will be the examination finding in the infrascapular region? And the options are hyperresonance on percussion, coarse crackles, dull note on percussion, and stridor. So if you look at the chest x-ray, it looks like a fluid level with a CP angle blurring, which is suggestive of pleural effusion. So there is pleural effusion on the left side, and they have asked what will be the examination finding there. Now hyporesonance on percussion, it is generally found in pneumothorax or emphysema, so that is ruled out. So coarse crackles, they are generally found in pulmonary edema or pneumonia, which is not the case here. Option D is stridor. It is usually found in upper airway conditions like tracheal and laryngeal lesions, so that is also ruled out. So option C, that is dull note on percussion, is the correct answer due to the decreased or absent breath sounds in such condition. So the answer here is option C. I hope guys this video was useful and this series was useful. If you like this series, do let me know in the comment section below. You can also DM me in my Instagram account for any help or any doubt. I will be happy to help. If you have not watched the previous episodes, I would definitely suggest you should go through all the episodes. And if you want to quickly revise certain important previous year question topics which are generally repeated in both Neet, PG and INICET, I have made a complete playlist covering many topics. You can definitely watch them. Having said that, I hope you all are studying well and solving MCQs daily. Wish you all the best for the INICET which is coming up. Keep studying, take care and cheers.